And in fact, the NICE guidelines in connection with lumbar pain or low back pain and sciatica only recommend manual therapy in conjunction with exercise.
Indeed.
But again, they don't say what.
And they don't say what and specify. I'd agree that the two together are a great mix. So totally just treating and no remedial work or remedial exercise to go with the treatment, I think, is limiting the scope.
What about the other way around? What about just exercise? I mean, again, have we got evidence to say that's not as effective?
Well, I don't know about the evidence, but I know from experience that, in fact, giving people exercises to do, encouraged by people who are not perhaps as highly trained, they can overdo the exercises or stop because they're painful. So you may not get the therapeutic value ongoing because people don't engage with them perhaps as fully as they might, because the way they're put across and the way they're explained isn't that thorough.
Yeah, okay. And that whole business, you said then that Cobra pose compresses the spine, could aggravate the problem. Do we have evidence to show that it does that? Hard clinical evidence, or is that just common sense?
If you ask people to do it, and in fact all of the things we're going to do today, you review with the patient, you have a dialogue, communication. It's all about communication and consent, but it's not just consent, it's about understanding and exploring with the patient, which is what we're going to do now, what makes things better and worse, not assuming that anything you think is good is for every patient, because that would be very limiting. And certainly that extension exercise in most people with acute back pain is actually fairly uncomfortable. Sometimes a little bit of engagement of the lumbar paravertebrals is a good idea to stimulate them, but with care.
So, from what you've just said there, how much do you vary the exercises you give your patients depending on the individual patient?
Well, each of the prescriptions I give are very much modified to suit the person to start with, to gauge what they can do. And then I have a set of, if you like, variables that I would make them slightly harder or give them the chance when I'm not with them, so in between sessions, to actually rein that back in again, so they still can do something rather than be feeling out of sorts that they can't do anything.
Right.
So leaving them with nothing in pain is absolutely not the way forwards. So they've got some modifiables within the prescription.
Okay. I do want. I don't know what your training was like when you went through the BSO, but I don't believe that we got very much as osteopaths in the way of education about rehab exercises. I'm not sure how much people even mentioned it. It might have been sort of.
It was more by accident rather than on purpose at times. I taught the clinical rehab course for 3 years at the BSO some time ago and wrote a lot of material. And I think it was also getting people to, I say dissect, again I keep using that word, but look at yoga and Pilates and actually break it down, not just say it's the answer, but it has to be for the individual. So even those well-established types of exercise that are often given out, I know, by osteopaths, it still has to be exactly what the individual needs, and I think there are limits. I know some osteopaths trained as Pilates teachers, and I know people have done other courses to bring that in.
And vice versa.
But as you say, at the beginning it was very, there was little of it, and actually some people say that is still not a major part of the course material.
Yeah. Lots of people would say that it's a big mistake, almost a red flag, to indulge in prescriptive treatment. Sort of, you've got this condition, this is your box of exercises, or this is the array of HVTs or whatever that I do. And I kind of get the impression that exercises do very much fall into that packet. There's a list, this is what we do for sciatica, go away and take these. And I have to say, I've not seen any of those exercises before that you've been doing, or exercises, examinations.
Well, yeah, examination, and they turn into remedial work. So you kind of, when I say remedial as against rehabilitative, they're slightly different concepts. So you're looking at people doing exercises that are not replicating necessarily exactly real life, and you actually get exercises that actually replicate functional exercise in real life. So the problem is actually, and why I think patients sometimes lose it, is that doing for example, a shoulder exercise that isn't actually really connected to what they need to do, like putting the kettle on or whatever, then loses some of the purpose in people's minds about why they're doing them. It's easier to do something that actually connects to what you need.